Hi, my name is Scott Hinckley. Before I begin my part of the presentation, I just want to mention that I work in a hospital as a respiratory therapist. So I have some personal experience with tuberculosis, and that'll be relevant a little later in the presentation. But wanted to explain my professional attire here for the video too. I'm wearing the scrubs that I wear to the hospital. I've also got the bags under my eyes and the 5-day stubble that comes after working bunch of 12-hour shifts in a row, so you're getting the full authentic experience. So I am talking today about treatment and prevention control. Well, first of all, there are two key tests that are used to detect tuberculosis. The first is the Mantoux Tuberculin Skin Test, or TST. This is the test that a lot of people are familiar with, where they do a subcutaneous injection. With a positive result, the person's arm will have a hard, raised, palpable area at the injection site. And the reaction must be read within 48 to 72 hours. Anyone that works in healthcare has probably had a tuberculosis test like this at some point. The second type of TB test, it's a little less common, is the TB blood test, the interferon gamma release assays, or IGRAs as they're commonly called. And I'll talk about that one a little bit later when I mention a personal experience I had. So now that I've covered tuberculosis screening, I want to talk about TB treatment. The first drug used to be effective in treating TB was streptomycin, an antibiotic. And the most commonly used antibiotics used today are isoniazid, which is considered to be the most effective agent against tuberculosis because it's able to penetrate macrophages and inhibits mycolic acid synthesis present in the cell wall. INH, as it's called for short, is used in combination with 3 other drugs, including rifampin, pyrazinamide, and ethambutol. These 4 drugs are typically taken once a day for 2 months for patients with the latent and active forms of TB. I should also mention that there is a tuberculosis vaccine called BCG, which is a live attenuated strain derived from M. bovis. It's not widely used in the US, but it is used in other countries where the risk of contracting TB is very high. And finally, for the scary part, there is a form of tuberculosis. It's not very common, but it is untreatable, multi-drug resistant tuberculosis. It's defined as being resistant to at least isoniazid and rifampin. So like MRSA, methicillin-resistant Staph aureus, it's manageable, but currently incurable. So next I'm going to talk about prevention and control. Prevention and control is very difficult in a public setting. Tuberculosis is highly contagious, so if someone has active TB, it's going to run rampant. It's airborne, so all someone has to do is breathe the particles out and someone else breathes it in. We've already talked about transmission earlier. Alice explained it well. So if you know someone has active tuberculosis in a public setting, you want to avoid contact with them, make sure you're disinfecting surfaces around them, wear a mask if possible, have the patient with active TB wearing a mask, and avoiding contact. In a hospital setting, like the hospital I work, they have very specific precautions set up for suspected tuberculosis. There are 3 levels of TB infection control in the hospital I work at, and I think it's pretty common amongst hospitals around the nation. The first level of infection control is administrative. So basically they try to keep the patient out of any public space where they could infect other people. So there are protocols put into place that isolate the patient. We would put a mask on them. We'd try to keep them out of as many public spaces as possible just to limit the area of contagion. The second level of control is environmental control. We have rooms on our medical floor and also in our ICU that are reverse isolation rooms that we put patients in with suspected tuberculosis. They have a negative airflow. Basically, it sucks the air out of the room. So that if there are any airborne particles, the idea is that they'll be removed through the ventilation system. We would also keep doors closed whenever possible, and then also limit access to the room for family members and also practitioners, just only necessary personnel. And finally, the third level of control is respiratory protective equipment. This is something that I use a lot in the hospital for airborne isolation rooms. The one we use in our hospital is called a PAPR. It's a powered air purifying respirator with a high efficiency filter. It looks like a spacesuit. You have a little motor that you connect around your waist on a belt. You attach it to a mask that you wear that covers your entire head, and it provides airflow inside the mask. But the idea is that it protects you from any airborne particles inside the room. So to close our presentation, I'm going to tell you a spooky Halloween story about a close shave I had with tuberculosis. I was working with a patient on our medical floor. We use standard precautions for all of our patients, so I went in and wore gloves. If they're coughing a lot or we're suspecting some other kind of infection, we wear masks as well. In this case, I was just wearing gloves, as were all the other practitioners. So I saw this patient 3 times over the course of the day. I gave him a nebulizer breathing treatment each time. If any of you have asthma or know someone who has it, you may be familiar with the device. But when you breathe in and out, it releases particles into the air, which normally isn't a problem. But in this case, I found out something terrible the day I returned to the hospital. That he was a suspected tuberculosis patient. And this has happened before, and usually there's no reason to panic. But in this case, the patient had shown 3 hallmarks of tuberculosis. They had done an x-ray on him. They had found what looked like tubercles. You see the connection with tuberculosis. Tubercles are granulomas that form in the lung tissue. They necrotize, the tissue dies, and so this is what in the disease causes impaired lung function, can cause patients to cough up blood. The second sign that he had shown was blood in his sputum or his spit. So again, another hallmark of TB, and he had also been sweating that night. Night sweats are another common symptom of tuberculosis. So there was fairly strong reason to suspect that it was a possibility. So at this point, the hospital notified me that I'd been potentially exposed to TB. Now, as I mentioned before, there is a blood test that they can do to determine if you have tuberculosis, the IGRA blood test. The only problem is that you have to wait 8 weeks between time of exposure and the blood test. So it was 8 excruciating weeks of not knowing whether or not I had tuberculosis, and kind of playing the what-if game in my head and planning for the worst, looking at undergoing a couple months of treatment, and limiting exposure to everyone around me. Thankfully, it came out negative. It ended up the patient had lung cancer, which some of those symptoms can look similar to tuberculosis, including nodules in the lungs. But still, it was a frightening close shave for me. So anyway, I hope you've found our presentation informative today on tuberculosis. Hope you learned something. We enjoyed researching this, and we hope you enjoyed watching. Thanks so much.